Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. First of all, thank you very much for providing me with this opportunity to be here, where I'm representing my colleagues. So, acute stroke care, what we are doing for our patients in modern day clinical practice. When it comes to stroke care in Pakistan, unfortunately, we are quite far behind, so still we have to catch up. But Alhamdulillah, in last 10 years, we have seen lots of change. Before I start, I would just like to present a case that happened, that came to us about 2-3 months ago at Shifa. That will give us a slight insight that in modern day clinical practice, wherever we have got some opportunity in terms of like modern investigations and interventions, we should think slightly out of box to provide best possible care to our patients. So he was a 44-year-old gentleman, diabetic, hypertensive, smoker, morbidly obese, 122. He really liked his food, still working as a tug master at Islamabad International Airport. He presented somewhere in mid-January with acute left side weakness and speech difficulty with NHSS, that is the stroke severity scale of 10. He was within time window of 2.5 hours. So he had a CT scan that was pristine clear with no established infarct or bleed, and his CT angiogram showed an unusual complete occlusion of his right common carotid artery, right up till the bifurcation in the carotid bulb. So after discussion with family, he was given TPA. Thrombectomy was not planned because access was not possible at that time, and he was admitted in the stroke unit. He was admitted for 4 days, where he had his initial rehab. He had all his investigations in terms of like his cardiac and hematological screen to rule out any sticky blood syndrome and that kind of stuff. And he was discharged on day 4 with NHSS of 6. So he started to walk with support, and we were planning that he will be going back to his work. But surprisingly, 3 weeks after his first follow-up, he noticed some transient loss of vision in the same territory in his right eye, along with recurrent weakness in the same left side. So his weakness that was improved from 1 to 3 in both arm and leg, that went back to complete hemiplegia on the same side. So he presented again to our emergency. I was on call on that week. So we had an MRI overnight, and that showed a new stroke in the same territory. That was quite unusual for us. So early in the morning, when I was seeing that patient, we had 2 choices. One, ठीक है जी, आपको एक नया स्ट्रोक हो गया है, दोबारा कमजोरी हो गई है, घर जाएं और इनकी खिदमत करें. Other choice was to think something different. So picked up the phone, discussed with my interventional radiology colleague, Dr. Atif Rana, and we planned to do DSA. And DSA really showed something very unusual. That was first time we all 3 colleagues have seen. His ECA was being filled by collaterals from the cervical branches of his vertebral artery. And there was an antegrade flow. This antegrade flow was basically forming blood clots in his carotid bulb and taking these clots up in his ophthalmic artery and the same territory where he had previous stroke. So this was his first stroke. This was his first CT angiogram that showed complete loss of flow in the internal carotid artery. This was his old diffusion restriction that was normalizing, and there were a few other cuts. I was not able to put them because of the slides, but there were like few new strokes coming up in the same territory. And this was the image that his ECA was filled from the vertebral branches, and it was basically retrograde and then antegrade flow in the internal carotid artery. So then, again, it was very unusual for us. Called our vascular surgeon and planned a procedure that was first time for him as well. So that was ICA ligation. Never seen in my life, never seen in our interventional radiology and also our vascular surgery service. So procedure was planned in regional anesthesia while patient was awake. We all were in theaters monitoring patient because we open vessels, but this time we were closing the internal carotid artery. So we clamped the artery for about 10 minutes, looked at for any neurological compromise because patient was awake during this surgery. It was uneventful. We ligated the artery. After that, patient, alhamdulillah, he improved and he went home. Now with a bit of rehab, his neurology has improved. He has started to walk again, and we are planning to send him back to his job in next few weeks' time, inshallah. So stroke services, as I said, we are very patchy. It's there in some bigger cities, but still we need to increase our network. In Islamabad, Rawalpindi, we have got 2 services, one a military hospital, Shifa, where we got comprehensive services right from A to Z. We have got Maruf, we have got Fauji Foundation, where we got sort of a drip and ship model. We can do TPS there, and we can ship patient for all interventions in other hospitals. And we have got RIC, where we have got no stroke unit, but we have got sometimes thrombolysis and thrombectomy services with good data as they present. It's not a disease of old age. About 4 out of 10 patients which we normally see in our inpatient as well as OPD, they are actually young, working group patient, both in males and females. I have got this data. I hope, inshallah, I'll be presenting in one of the upcoming meetings within the next 3 to 6 months. This was history. Even in the established healthcare services, stroke was looked after only in the nursing homes by the GPs, but now it is hyperacute. From EMS training, now services have changed to even mobile stroke units that we are going to discuss very briefly in next upcoming slides. There are 3 main determining factors. One is the recognition and transfer that we have to our community needs to be educated. Our emergency medical services that is currently being looked after quite well, at least in Punjab. We need to teach them in terms of like acute recognition, because it's very easy and patient needs to be transferred appropriately to the right centers. Then we have to collaborate in our emergency services and the radiology services, because this 1 hour is the mainstay where precious time is lost, and patient all necessary investigation and interventions should be done. Sorry. And then stroke unit. I think this is one of the most important requests from today's forum, because we have got people from all across Pakistan. Wherever you are working, kindly start developing stroke units. We talk a lot about thrombolysis, thrombectomy, and all advanced services, but all these will come once we have got the basis stroke unit. Playing field hogi, to sab kuch aa jayega, inshallah. So it's the #1 cause of disability on its own. It's the 5th leading cause of death as per CDC. Our data is very patchy. Our stroke death rate is much higher as compared to the rest of the world. It has got huge impact on family and community, because we have got no social service. All brunt is borne by the family in terms of like their cost of living, loss of earning, and support. Worldwide, 15 million strokes. 5 million of them die, rest are treated. Pakistan, 250 per 100,000, that makes around 500,000 new strokes. In Rawalpindi, in Islamabad, with population of 4 million, it makes around 10,000 new strokes every day. And we have got not a single public sector stroke unit in all the teaching hospitals in Rawalpindi and Islamabad. We have got no data because we don't have got any established services. And the alarming thing is that our stroke-related mortality is around 30%. So this is the number that can be fairly reduced from 30 to 11 and 12. Only we need stroke units, that's all. So these are the old targets from NINS 1995 for door to needle for hyperacute services. Wherever we are practicing in Pakistan, in majority we are achieving, but still we are far behind because these targets have also been reduced in recent times. So the most important slogan, again, a take-home message from here: time is brain. So 1.9 million neurons per minute for even large or a medium-sized vessel occlusion in case of acute ischemic strokes. Wherever we are, we have got multiple, they are available, they can be easily accessible from the internet. These are the stroke recognition scales. We have to go to the local schools, local medical colleges. We have to teach and train our emergency medical services. Few of them are more sensitive, few are more specific, like Be Fast, Melbourne, or CPSS. So they can be implemented in our health system so that the precious time where brain is lost, where neurons are lost, they can be looked at. So transfer model, these both, as we are using actually in our opinion in Islamabad, that is the mothership model and the drip and ship. Mothership, where the patient is directly transferred to the unit wherever thrombolysis and thrombectomy both are available, or we can have the drip and ship model where patient is thrombolized in the initial draining hospital, and then patient can be shipped to a comprehensive to avoid any delay in terms of like thrombolysis, because thrombolysis is still the gold standard, and patient who is a candidate should be given, and the RaceGate trial has clearly shown that in both cases the results are comparable in terms of like modified Rankin scale within next 30 days. One and the most important, I think, telestroke again for us, because our health system is still very patchy. We have got established tertiary care setup, but we don't have got secondary and primary. So we can develop wherever we are telestroke, and telestroke is far superior as compared to the telephonic, and we are trying to implement this in our system. We are still in early phase because there are a few hitches, but still it is very easily doable in our system. Drip and ship model and dip and ship, there have been few studies and they have shown very promising results that in case patient can be treated wherever they are, if there is a bit of political willingness, a little bit of training, and some use of technology, in hospital stay and mortality, length of stay, discharge, disposition to the local area, and the outcome is much better if patient is treated wherever they are, because time lost, brain lost, so we can very easily treat patient in hyperacute stage. Mobile stroke unit, this concept is not that new. Christine Kolvig, I worked with her. She devised first stroke unit in Germany, Heidelberg, back in 2010. It has got very significant effect, and now all of the Western Europe and Northern America, they have been utilizing their mobile stroke units in majority of their healthcare setups. We are far from this kind of setup, but still this is something that we should have in our minds. It shortens the time of onset to thrombolysis. It increases the rate of thrombolysis because more patients are recognized, we get more patients within time, and it optimizes the pre-hospital triage because better patients, they can be transferred either to the units or to thrombectomy suites depending upon their time of onset and eligibility. Then again, one of the most important factor that is also helping lots of patients, and actually even at Shifa, we are moving towards this now in last few weeks, that previously it was onset to time window, but now it is time to tissue clock approach. But definitely it needs a bit of more political willingness, because our stroke services will be more upfront. We will be seeing more and more stroke codes. And second, we need a bit of technology because we need MRIs and we need CT perfusion. CT perfusion is very easy, though it is now expensive because the rapid software costs around 7 to 8 million per year, but it can be used even by doing manually. We as fellows used to do. It's very easy to be interpreted, but all the recent trials they have shown in favor, like wake up, pause and extend, because majority of patients which we normally see in our clinical practice, they are sort of in early morning or wake up strokes. So lots of patients can be benefited if we just think slightly more in advance, and we can start shifting our practice from time of onset to tissue clock window, where we have to look at diffusion flare mismatch or CT perfusion where there is a sizable penumbra. We can recruit them for our thrombolysis or thrombectomy, whosoever is within that appropriate time window. Then this is the new kit on the block, 10 active plays. Lots of discussion on this. Again, this is a new genetically engineered mutant tissue plasminogen activator that is better tolerated. It has longer half-life, and it has got advantage that it can be given as a single dose push rather than 1 hour that we normally wait for traditional IV TPA. It has got better specificity and it's tolerated much better as compared to plasminogen, tissue plasminogen activator TPA, and it has got less allergenic issue, as we see, because we see that patients who are with ACE inhibitor with TPA, we see more allergic reactions. And a recent meta-analysis has shown it is slightly superior in large vessel occlusion, especially the patients who are going for thrombectomy as compared to TPA in 3 months modified Rankin scale output. These are various trials that have been completed with good results, even up to 12 hours and 4 and 4.5 hours. A few are still underway, but it is in guidelines now. AHA and ASA has given clear guidelines in 2019 that all patients who have got no contraindication and who are planned for thrombectomy, they can be given 0.25 milligram per kilogram as a single IV push if they are within 4.5 hours. Or if patients who are medium or small sized strokes who are not considered for IV, for mechanical thrombectomy, they can be given slightly higher dose of 0.4 milligram per kilogram single IV push. Europeans are slightly careful. They have given the guidelines of same 0.9 milligram per kilogram, 0.25 milligram per kilogram in both cases of large vessel occlusion for mechanical thrombectomy and for smaller vessel disease patients. Endovascular recanalization, this is something slightly older, already established in majority of healthcare setups. At Shifa, we started mechanical thrombectomy after Swift Prime. Since 2018, we have done more than 50 with very good results. Initially, it was like up to 6 hours, but now after dawn and diffuse, the window has extended from 6 to like 12 or even 24 hours in majority of healthcare setups. But again, here we need either CT perfusion or MRI, where we have to check diffusion versus flare mismatch. I don't think we need to go into detail of this. This is our stroke algorithm at Shifa. This is current situation in Pakistan. We have got 16 centers offering TPA only, with 14 centers where I got actually units. Other 2 units, they have got ICUs where they manage patients. CT and MRI availability is there, but cost is a major factor. Now in some government setup, that is becoming lesser, but in all private, that is more than 200,000 per single unit cost. Mechanical thrombectomy is there only in 6 hospitals. 3 of them are in public sector, rest are private, and there's a huge cost associated with this. So we have to start working on this, especially in our public sector. In terms of teaching and training, again, we are slightly lagging behind as compared to rest of other specialties and also the rest of the world. So one public sector teaching hospital is offering fellowship in neurointervention and mechanical thrombectomy in Lahore. We have got 1-year stroke fellowship that are 2 centers, one in Shifa and one in Karachi. That is purely medical fellowship. Pakistan Stroke Society is working on workshops, GP training, EMS training. We have organized a session nationwide where we have trained 1122, Al Khidmat, and rest of the ambulance services for early recognition of acute stroke. And we are also starting our awareness campaigns in schools now in Twin Cities of Rawalpindi and Islamabad. I'll be just finishing in a couple of slides. So ischemia, cytoprotection, basically it's not only the neurons that are affected, it's microglia and all the supporting and endothelial network. They are also affected whenever stroke strikes. What helps is basically adequate blood pressure control, metabolic milieu temperature and age of the patient. They are sort of determining factor. There was one recent trial, but that has not shown any significant results. That is the ESCAPE NAI that looked at the effect of neranitide, that is a PSD95 inhibitor. But in both arms, there was no significant difference in terms of like long-term follow-up. So we have to develop more stroke units. We have to develop hotlines where we have to educate people. We have to recognize stroke early. We have to bring them into the service. Pre-hospital care should be optimized, and last, stroke units wherever we are working. Still we are in words, but still there is a ray of hope. So I hope if we work together, we will develop something for a better outcome. Thank you.